So next, Dr. Barbara Hanek is going to talk about taking care of treatable animals in her shelter. Dr. Hanek is the director of shelter medicine at the no-kill shelter PAWS Chicago. She's worked in private practice for 20 years and started doing some volunteer work for PAWS Chicago with some of their difficult animals, and eventually got wooed over to work for the shelter full-time. Her shelter is under Barbara's direction. PAWS Chicago takes in about 3,000 animals from animal care and control, and about 38% of their intake is what's considered treatable. So with that, I'd like to have Dr. Hanek come up and tell us how she takes care of all those animals.
And very excited to show how we decrease the pet overpopulation and also decrease euthanasias. At PAWS Chicago, we have this adoption guarantee component, and it's a model that we use. And first of all, it's a commitment to Chicago's animal care and control. That's referred to as ACC, and that's Chicago's only municipal facility. And by treating the treatables through our rescue and recovery center, and that's where I work. We also have focused accessible, targeted, high-volume spay-neuter program, and that's a very important factor in determining pet overpopulation. Saving lives through our Lincoln Park Adoption Center, which opened in '07, and it's an off-site facility from where we do the rescue and recovery and the surgery. And also being partners and educating the community on the importance of spay-neuter. We're very involved in a TNR Pharaoh project also. And volunteers, the heart and the soul of the organization. And just to show you, last year, 91,000 hours were volunteer hours, which is equivalent to 44 full-time employees. So we definitely accept help and wouldn't be able to survive without it. Since our founding, which was approximately about 14 years ago, euthanasia rates in Chicago have decreased over 60%. You can see this map here as far as the founding of PAWS here back in about 1997 or so. Over 42,000 animals in Chicago were being euthanized. And approximately now, say 2010, roughly about 17,000. So we feel like we were making a dent in the pet overpopulation problem. And our commitment to animal care and control, pulling from the city pound, that we're very proud to be the largest transfer partner. You can see here back in 2009, 2010, total animals that left animal care and control, roughly 2,600, and we've pulled probably 75% of them. And then likewise in 2010. Each week we're there and we're pulling anywhere from 65 to 80 pets, dogs, kittens, cats. We're pulling them each week. Sometimes we're there we're there at least daily. Sometimes we're there twice a day. And our commitment to Chicago's animal care control will enable Chicago to be an adoption guarantee city in approximately 3 years, is what we're on target for. You can see these two graphs here as far as this is the spay-neuter surgeries done at our facility, and these are in thousands, and obviously this is a 10-year span for both of them. And we have approximately a little over 17,000 surgeries that were done. Let me just kind of get caught up here with mine. I can see the numbers a little better. Roughly about 17,000 surgeries that we do at our facility every year. And this year we're on target for 18,000 surgeries. And as far as adoption history, in 2010, we're approximately on target this year for 4,400 adoptions per year. And to go to the next section. Now this is from animal care and control, and you can see the two lines. This one is their intake, this is their euthanasia. So we feel like their line of intake has decreased, and that's especially with focusing on the spay-neuter program. So kind of looking at this graph here, and then also the decrease in euthanasia is partly due to the decrease in intake, but also due to our increased adoptions, because we're there pulling all the time. So they can put less animals down. And that just shows it. Another component of our model is targeted and accessible free or low-cost spay-neuter services. And this is providing a solution to those most in need. This is a different wards of Chicago. And you could see the southern section of Chicago is a lower income part of Chicago. And this star right here is where our facility is located, where we do the spay neuters and also the rescue and recovery. Our adoption center wasn't there in 2001, but in 2007 was built in the Lincoln Park area. So that's where our animals are adopted. And you can see here, the red areas show the 600 calls or plus, as far as stray neuter calls that have been received by animal care and control. So 17 wards were this red area. And in 2010, 9 years later, we've got 5 wards that are 600 calls plus of stray calls. So we feel like we're making a difference, as far as overpopulation. And interestingly, just within the last month or so, we were able to not only secure funding, but we received for a spay-neuter van. And, where the first place it's going to be is this section here. So again, to bring that, focusing on that targeted area and see if we can put a dent in this population. And if ever I come back to talk to you, hopefully there'll be no red on this. That would be nice. This is our facility here. This is our Lurie low-cost spay-neuter clinic. And we've done so far 110,000 surgeries, 63 which were free. 63%, I'm sorry. That'd be bad if it was just 63. But 63% that were free. And so in 2011, we're on track for performing over 18,000 spay-neuter surgeries. And on average, that's 84 surgeries a day. You can't see it here if you look real closely, though, but let me go back. There's the surgeons are tethered to the surgery tables. We don't let them walk away to eat or go to the bathroom or anything. So to do 100 surgeries a day, you really have got to be cooking there. So 4 surgery tables, and the techs are really great about keeping them prepped. And outside here is our surgery prep area where we have a couple of sinks, and that's where the cat castration's done are also. We're really proud of the work we do. This is at the Rescue and Recovery Center, and that's located in the same building as the surgeries. The surgeries are done on the first floor. The Rescue and Recovery Center is done on the second floor, and we're really proud. I keep thinking this is the laser part. This right here, the 97% save rate, and we do pull high-risk animals. This right here, we'll see pets not only malnourished, but we've diagnosed EPI, exocrine pancreatic insufficiency, where they've required, and we pull high-risk pets too, as far as moms that are just gave birth maybe a few days prior. And it all depends on the staff that we have as far as our capability. This right here is our adoption center, and like I said, this is in Lincoln Park, and it's been open for 3 years, and so far 12,000 animals have been adopted. And again, in 2011, we're on target for hitting 4,400 adoptions. How to successfully treat the treatables. Understanding your capacity. So that's just the sheer size of your facility, and maximizing your resources. Organizational and team member accountability and communications, really important. Processes that are followed consistently and leverage the skills of your team. Standardized medical protocols and processes. I was in private practice for a long time, and when I joined shelter medicine, it really surprised me how I really thought each pet would be treated individually, and I would have a different treatment plan for each. But then as I did it, and it was just the sheer numbers of it, I realized that, no, you find out what works, and you find that that for the most generalizations that they can be treated somewhat similarly, and then you'll always have those exceptions where you need to go up and above, the basic care. Address and manage the dynamics of population management. Define goals and measurements, and at PAWS Chicago, we're really big about having certain goals and making sure that throughout the year that we're on target, and if not, how can we get there? And that font is probably not large enough, and is foster. We could not do the work that we do without having the support that we have by the community. People coming in and taking kittens, and actually we have some awesome fosters that they want sick kittens. They want the ones to nurse better, and even though sometimes their hearts are broken when they die of panleukopenia or something like that. So we're really blessed as far as having an awesome foster group. So this is the heart of the talk, and this is talking about the process. How do we do this? And maybe how do you do this in your own shelter setting? And that's selection. It's broken down in 6 groups, and we'll talk about this. So selection, health assessment, daily rounds, medical treatment, adoption center, and post-support. So it's kind of a whole journey that the pet's going to be on from ACC, from being into the selection process all the way to after they're adopted. And selection, again, depends on the capacity that you have and just the sheer space that you might have. And at the Rescue and Recovery Center, we can handle anywhere from 75 to 120 animals comfortably. Foster, 135. It's not uncommon for us to have 150 animals out in foster, and especially if we're having an adoption event, adopt-a-thon that we have maybe throughout the year. Sometimes that number would be much larger. At the adoption center, anywhere from 110 to 145 animals. Space utilization, and this is looking at more of this Rescue and Recovery Center. This is kind of a simplified layout of our second floor, the Rescue and Recovery. And you can see these are all the different rooms that we have. And it might be like the ACC room where we have cats, ISO hall, which would have multiple rooms where we would have cats and sometimes dogs also. Excuse me. ISO kitchen, just because it's off the kitchen. Exam room, this luxurious big room is about the size of a closet. And that's where we do the exams. Excuse me. Abbott, this is a large area where we house the dogs. And you can see some of our staff here too, like animal care manager. This is Heather, who's going to oversee all the animal caregivers, the ones that clean and feed. Population manager, this is Kristen, who sees what we have at the adoption center, sees what we have in the facility, what do we need. And the shelter medicine assistant, this is after I do all the records. She'll input all that information into the computer as far as what's been done, what needs to be done, surgery papers, things like that. So just different areas here. And this is meet your match room, a little play room where the animals can kind of run around if they're indoors. And then just different storage and such. Selection, we look at it as 2 ways. We have a fast track and a slow track. We do best when we have 65% fast track and 35% slow track. Fast track, I should have practiced though. Fast track, we're looking at, we pull from ACC and also owner relinquishment. So ACC, it might be an adult animal that, it's the time that it takes from going from ACC through our facility to the adoption center. And sometimes it can be within 24 to 48 hours. So if we're pulling an animal, beagle that is 3 years old, already spayed, needs no dental work or mass removals and looks healthy, then it would go right up to the adoption center after it has our medical protocol done. So again, dogs over 7 months of age, dogs and cats over 7 months of age, and again, we pull from the ACC, from the city facility, and also owners that relinquish their pets to us. If they're all ready to go, we vaccinate them. And if puppies and kittens on Saturdays, we have what's called owner relinquishment, where where maybe we'll just do their first set of shots. We know that we'll be getting the kittens in another 2 weeks. But what we'll do is do the first set of vaccinations, and maybe they have a little bit of upper respiratory or something like that. We'll even give them medicines, and they go home. In 2 weeks, they come back, hopefully healthy, second set of shots, and that can be fast-tracked. So then potentially we can get a 10-week-old kitten not in our facility, not catching diseases, etc., and right up to the adoption center. If an animal is sick, like I said, we'll provide medicine. So that's fast track. As far as slow track, we consider adult animals that maybe need some other care. Maybe they have respiratory or GI problems, and or they have a mass that needs to be removed, or poor dental condition. So, and again, we pull from ACC, owner relinquishment, and these are the ones that are going to be staying with us greater than 3 days. So sometimes it might be 10 days, or it might be longer, depending on if they might be diabetic. We might want them in foster to get them regulated, things like that. So, and slow track, we have the adults that are older that need medical care or surgical care, and anything up and above our regular medical protocol initially done. Slow track, we have the kittens and puppies, and we don't like to push those through. Kittens are probably our highest risk group. We like them to have a couple set of vaccinations, and we do it. We start as early as 4 weeks of age. We vaccinate them every 2 weeks. And after that second set of shot, then they're usually cleared for surgery. And once they're cleared for surgery, then they can go up to the adoption center if they're healthy. And again, it's the fosters that we rely upon for the kittens and the puppies, especially. We try to, we joke about 3 paws down and they're out. We don't even want them staying long enough to get comfortable to put the 4th paw down. We want them out of the facility. And for as much as I think PAWS is a great facility, it's not the best place. It's the best place is in a home where they can stay healthy and they can be observed, and again, owner relinquishment. So as far as selection, the animals that we pull, especially from ACC, you're going to see, this is somewhat of a busy slide, but you've got like the cats, like half of the cats are going to need additional care as far as medicine or a procedure done. Dogs, probably about 30%. So on average, 38% of our new intake require medical treatment or even surgical treatment beyond the standard protocols. And I'll show you our protocol in a little bit. And again, like I said, the population target, we try to have 65% fast track, 35% slow track. Our intake from animal care and control, this is going to summary that 20% of our cats, about 20% of our dogs are going to, so about a fifth, going to require additional medical care, surgical care, and also 75% of our kittens and 60% of our puppies require additional medical care beyond our initial protocol. And 75% is a fairly high percent, but I think that just goes to show how aggressive we are as treating kittens. They might have a little serous drainage, and if that's the case, I'm putting them on doxy. I don't wait for it to become nasty and whatever. And most of the things that we're going to see are viral anyway, but we don't wait for them. We know that if one's sick in the litter, as far as respiratory, that most likely the other 4 are also going to get signs. So again, I think we're pretty proactive as far as using doxy for respiratory. Or maybe we have a kitten that's loose stool or something like that, and as long as it's parvo negative, it's not uncommon for us also to give marquee or to treat coccidia or do a fecal or whatever else. This slide is again busy, but let me try to break it down a little bit. This is by year, so here's 2006, 7, 8, 9. It just goes to show you as far as, and this is our intake history as far as dogs and cats. And it shows you as far as maybe here we pulled almost 1,000 in 06, maybe 1,700 in 07. You get to a certain point where this is where a lot of our organization changed in regards to our staff. So maybe we just had surgical vet here, and then maybe that surgical vet even did some oversight with the medical problems that might be present. But then right around here is where we went to a full-time veterinarian, that's myself, and then we also work with Purdue with the help of Maddie's fund. Purdue is establishing a shelter medicine program, so we have a fellowship, so we're currently on our 2nd fellow, and also we have a doctor that works the weekends as far as, and actually what's so nice is that it's our 1st fellow that finished, she works the weekends, so we have really nice continuity. And also with the CVTs and the doctors, a lot of times there's one person overlap, so we kind of have that continuation of care. So I might work Monday to Friday, and then the one tech works Friday to Saturday, and the other tech works Sunday to Monday. So it's kind of a passing of a baton a little bit. So nobody walks into rescue and recovery and doesn't know what's going on as far as ones that we're worried about. So it's really, really nice that way. And then also our additional staff, you see here, we just had maybe like an animal care manager, things like that. But again, here we're a little bit more ramped up as far as we've got the animal care manager who oversees all the animal caregivers, and then also the population manager. So we pull what we need, and we keep pulling aggressively. Health assessment. So this is the different part of the process, and it starts at ACC, Animal Care and Control. We have an intake team here. This is George and our CBT, KT, and there she'll do the, George is very involved with doing temperament testing, and KT will be there more from the health aspect. So she's going to do a physical exam, and it's not that we don't pull sick animals, but we like to be proactive and know what we're bringing in. So if we have an animal that has severe periodontal disease, has mammary tumors, maybe bladder stones, then there's no surprises. We know that we're going to be doing blood work on them initially, as far as to make sure that they're healthy. And also she does some diagnostics there, such as heartworm for the dogs. While there we couldn't get imidacide. So it's important that if we're bringing in a heartworm positive dog, that we know that we can treat it appropriately. Things like that. So CBT does the initial medical assessment, like I said, some diagnostics. For the cats, we'll do the triple test, so the feline leukemia. We do bring in FIV. Sometimes they jump up and down when we've got FIV positive, but feline leukemia we do try not to bring in unless we think it's a kitten that might convert and eventually test negative. But and then CBT confirms and finalizes, just gives a call before she heads back to rescue and recovery, lets her know that what we're bringing in. So this is their physical exam, the CBTs, and it just shows a couple of things as far as some of the diagnostics that they might do, whether it be cat or dog. Body score gives us a rough idea. Physical exam, if there's anything that really stands out, and their comments, needs a shave down or what have you. This is Dr. Campari. She's our second fellow. And so discipline and consistency, such as the process, documentation, decision, are vital to population management. And this is key here. Be flexible, proactive, diligent, and smart in your daily practices. We just keep trying to figure out how to do it better, how to do it more efficiently, and that really helps. And very flexible. It's a very dynamic process. The whole shelter setting is almost like a living being, and it's up to us to kind of keep a finger on the pulse. And there's going to be times where we have outbreak. It might be ringworm, it might be pan-luke, where we have to kind of step up. It might be just cat diarrhea or something like that, where we'll kind of adjust depending on the pulse of that living being. So. Rescue and recovery. Intake team weighs and puts assigned areas on the assigned areas. They put the signage. And what that does is it just helps us. Once we've got a weight on them, we can set up for them so when we get the animals out, we're ready to go. Signage might be if they're going to be fasted. If we have a nursing mom, we know that she's not going to go to surgery the following day. There's no sense of putting up the sign saying, NPO kind of thing. Treat a variety of things as far as some of the parvoviruses, ringworm, heartworm, upper respiratory, skin disease, cancer, somewhat limited as far as surgical removal usually, diabetes, hyperthyroid. This is our sheet that we I redesigned it because the sheet that I had before, the physical exam, was kind of a general physical exam that you might find just in private practice. And to me, a physical exam that's done in a shelter is still very thorough, but it's, you're focusing on some of these different things. So especially when I have a doctor that's there that maybe isn't normally with us, it's important for me to know that they're looking at things like oral ulceration, as far as looking for caleci, that they don't have crust, because again, we might be a little bit more sensitive to looking for ringworm. So it's important for me to kind of customize this protocol, customize this physical exam sheet. So if they're lame, that we're looking for some of these things and making a note as such. Doxy, you could see we use a lot of it is on our permanent physical exam sheet. So again, this just kind of expedites things that I don't have to write it 200 times. And then usually, this is important, this gives them direction as far as where they're going. Does the foster coordinator then look at this and say, okay, I circled foster and I put 2 weeks, or I put foster coordinated and I'm worried about it, so I want to see him back in 5 to 7 days. So again, it just gives them direction as far as what's happening with this dog, or we have a sheet also for cat. And then health assessment, they then go down to if they're cleared for spay neuter, if they're done with their 2-week hold, if they're slow tracked, then they go down spay neutered. We also do surgeries for the public as far as just spay neuters. Nothing else is done for the public as far as that goes. Special ops, usually on Fridays we'll have, that's a slower surgery day where we don't have a full staff. It might be one technician and the surgeon, and we'll do things like cystotomies or mammary tumor removals or enucleations or amputations or full mouth extractions for stomatitis or something. So that's kind of how we're set up. And the things that, so we've done a lot of outside care. We've brought a lot of outside care in. The only thing that we really send out would be the, so say it needs a lens enucleation or something, lens extraction, or orthopedic, say it has a cruciate, imaging, x-rays, and then they're cleared for surgery adopt. Our CVT, and this is our first fellow here, Dr. Nichols, along with KT, administers morning, and so she'll get in first thing in the morning before I even get there, and a lot of times even before the animal caregiver gets there, and it's nice because they're not conflicting as far as space, and she'll go ahead and do the morning treatments, and then also we have a technician that'll come in to do the evening treatments. And during that time, she identifies any major medical issues or changes in condition. So we might have a kitten that's not really down for a recheck, but she looked at it, it looks more quiet, or it's not looking like it's eating or something like that. So then we'll pull the record and make sure that we check that pet out. Medical observation sheet. On each cage and you'll see there's a medical observation sheet. So the animal caregiver, when they're feeding, cleaning, they'll make notations as far as if there's vomit, diarrhea, anything like that. So the CVT is going to see that and again pull the record so that I can go ahead and look at it. Assist with patients' initial protocols. So a lot of times you'll see, again, like if you look at this line here, the technician, when she's over at ACC, we believe so highly in the importance of the vaccination that it's done before it even comes into our facility. So when she's doing the heartworm test or the feline leukemia test, she's also vaccinating them. We don't want them in our facility for several days because the vet didn't get a chance to look at them, and meanwhile now they caught something. And I mean, so days or hours are critical to us that we want them vaccinated, ASAP. Now that might be done on, say it's done on a Monday. And then they might not come to us as far as by the time that all the animals are done at ACC, by the time they come in, it might be 3 o'clock, 4 o'clock, sometimes even later. If I've got other things to do or I can't get to them before I leave that night, then what I'll do is first thing in the morning, I just come in, do the exam, rabies, they're ready fasted, and then they go, if they're fast tracked, then they go right down to surgery. Fills prescriptions, completes medical plan, things like that. And this is a very special, this is Valentine, this is a very special mom that we had that was nursing, I don't know, say 5 pups, and then we had another nursing mom who wasn't accepting her pups as well, and so this mom stepped in and helped us out, and nobody does a better job than mom when it comes to nursing kittens and puppies. And an initial medical assessment, ACC, we talked about. Daily rounds, this is the medical sheet. Well, a sample of it anyway. Usually we'll have a sheet for each section, so Abbott would have a sheet, ACC is going to have a sheet, and it's going to tell you where they're at as far as the location, dog or cat, what medicine they might be on, how often, and when they started, when they're finishing, so if we know if we want to extend it or not, and then the CVT goes ahead and initials off on it. Daily rounds. The animal is also assessed by the animal caregiver. Like I said, there's that sheet right here where it describes appetite and stool and urinary vomiting, things like that. So the animal caregiver is also responsible for doing the basics, but also looking at how they're doing clinically. And our animal caregivers, we tried to assign them to areas that, depending on their skill level. So if we have ringworm, if we have a high-risk, more contagious disease, such as, dog parvo or feline parvo, such as Panleuk, we want them to not be of fomite, so they're skilled. They're not going to use the same gloves for each cage, or they might, gown up and things like that. So again, you might have animal caregivers that just like to feed and pet the cats, and that might not be a really good idea if you're dealing with an outbreak of diarrhea. And the veterinarian also does daily rounds as far as looking at the general population. But also I think what's really important is at least once a week what we try to do is go through the whole place and just see, especially if you have a moment where it's not as crazy, you're going to go around and see who's here, or why is this animal still here? Is there anything we can do to help this animal get out? We really believe in having a very fluid facility. We want things moving. We don't want the shelter setting is not the place for them as far as mentally and physically and all as far as that goes. Prioritizes patient care, workload, and resources upon arrival. So depending on what kind of help I have, I may say, okay, can you get weights and temps on these guys, and so we'll kind of divide and conquer. And it all depends on the workload too. You might have days where getting through the box is not a big deal, and then you have other days where there's 2 boxes and they're busting, as far as with records, as far as patient to be seen. So does what only a vet can do. And that's really ideally only what a vet can do, because usually the vet, we're taking out the garbage and all that stuff too. So basically we all pull together as far as just to get the job done. Provided with the animal inventory, foster, surgery schedule. So I'll have a few pieces of paper as far as lets me know an inventory where the animals are, as far as ABID, ACC, down in the clinic. I'll have an inventory as far as who's here and where they're at. I'll have a surgery schedule as far as who needs to be cleared for surgery that morning. And usually we try to have them done by noon, so the surgeon knows we're not bringing animals down at 3, 4 o'clock, and they've already started on cats, and they do dogs first. Support team needs to make the vet as efficient as possible. Just like any great tech, they're going to stay a couple steps ahead of you. And the vet needs to educate, train, and delegate, and hold the shelter medicine team accountable for providing high-quality care. We try to treat them like they're our own pets. Integrates the Purdue University Shelter Medicine Fellow and externs. We do get externs, whether they be Purdue CVTs or senior students from Purdue. So incorporating them and having them be a learning experience for them. So this is just kind of an average, just a summary a little bit about what we do. CVT is going to provide medical treatment and rounds. The vet's going to review the population, determines priorities. We're going to clear them for surgery, hopefully by noon. And we also have fosters coming in at that same time. So slow track, we also do the rechecks of ones that we might be worried about or ones that we might hope to clear. And the CVT meets with the intake team at ACC. So roughly about 10 o'clock, they're going to meet the intake team as far as to do some of the health assessment over at ACC. And they might be gone from, say, 10 in the morning until 2 in the afternoon or so. In the afternoon, this is Hank, who was likely had some type of burn, whether it be chemical or heat burn or thermal burn at ACC, and we pulled him, and he's healed beautifully. As far as afternoon, we try to see the new intake seen by the vet, so we don't have to have the pressure of doing it the morning before noon when we have all these fosters coming in. Diagnostic testing, so we might be running some blood work, things like that. Dips that are usually done in the afternoon if we have ringworm or suspicious ones. Intensive care, that's done in the morning, and we'll check them throughout the day if they're on IV fluids. And foster rechecks, CVT, medical treatment and rounds. File review, it might be a pet that's going up for adoption and it has a fairly long history and they don't want it summarized, so for the adopter, and we'll go ahead and do that. And then we try to wrap up the day. Respiratory disease, this is Tyro, and actually Tyro looked much worse when he first came in, and Khaleesi, just sloughing the lip and the nose and the tongue and all this nastiness. Body score of probably not even 1, and it was looking better here and really great here. And it looks like it's on somebody's belly. I'm thinking that's a foot, So I can only imagine. As far as respiratory disease, I'm a big believer in weight. I don't think I've ever lost an animal that has been gaining weight. So, if you just gave me weights of an animal, especially the young ones, the puppies, I can almost tell you, who's failing just by looking at that value alone. So, to me, weights are critical, much more so than even temperature. If I have a temperature on a cat, 102, 104, 106, I'm going to get concerned about it. But, if I've got a kitten that's gone from, 1 ounce or 1 pound, 6 ounces, and it's now 1 pound, and it's been 2 weeks, then I know that we better step in, intervene, and find out how we can make that pet thrive better. So monitoring temp, fluids, food and water, just like us, pretty basic, but it's not uncommon if I'm worried about them for me to put them on, just to put the orders down, sub-Q fluids for 3 days. Maybe I'll give them mirtazapine because I know that that's usually every 3 days too. Syringe feeding I might put down automatically, and then for me to recheck them on the 3rd day to see if we need to continue treatment as far as sub-Q fluids, or sometimes we'll check them daily. But again, I've got other people looking at them too, so it doesn't just fall upon me. I've got CVTs looking at them. I've got animal caregivers looking at them. So often are a variety of food. Sometimes they love the AD, sometimes, Evo, it just depends on just kind of opening up a whole big cans of food sometimes that we've been donated or that we have. Antibiotics, Doxy is the main one. Proviable, I'm pretty much a lover of any probiotic, whether it be, especially for respiratory or GI, but sometimes for just general health. Nebulize if they're pretty congested. Sometimes I think these Khaleesi cats need some type of pain relief. So sometimes, if I see a cat that maybe doesn't have oral ulcerations, but they're kind of swallowing hard a little bit, sometimes I think Carafate might help. So again, just being open and looking at the pet and seeing what else we can do to help them along. Diagnostics, not done that often, but if I have a real chronic respiratory, I think that finding out what bug is there and if it's resistant to everything. And ringworm, we do treat. We've done as many as over 100 dips a day when we were in outbreak mode last summer, end of the summer. So we treat until we have a negative DTM at 21 days, or if they were positive, the initial was positive, then 2 negative DTM, so we'll continue treating them. And that usually means internally and externally. So internally is going to be itraconazole daily, and I know there's a protocol where you can kind of break it up, but we do the itraconazole daily with food. And lime sulfur dips, and we do that twice a week. Isolate, of course. We do a toothbrush method, and we also will pluck the individual hairs if we have cross or alopecia. So that's what we talked about, lime sulfur dips. Sometimes we're even proactive about that. If we're in outbreak mode and nobody's clinical, nobody has signs or anything, we'll go ahead and dip them just on intake. We haven't gotten to the point where we've needed to do that all the time, but especially during our outbreak mode. So again, it's treating this as a vital, living, dynamic being, and then adjusting your treatment depending on the conditions and the health of the shelter overall. Gastrointestinal, this is Toby. Toby, he was a sad case. It was one of those where it's like, oh, come on, how did we pull this dog? He was a puppy that was lateral recumbent, could hardly lift his head, extremely emaciated. I'm like, they're having a lot of confidence in our ability that we're pulling this one puppy that's near death, and his head looked like it was stuck in like a bus door or something, and just really lifeless, and really bounced back nicely, and just makes us a believer in what we do and wanting to take more and more challenges on. But we talked about monitoring of weight, again, even for GI. Fluids, food, again, that's pretty important. I use a lot of metronidazole. Antiemetics, unless I think I've got a foreign body, I stay away from the metoclopramides and things which increase peristalsis. But depending on the severity of, and sometimes IV fluids also with these. I do use a lot of Panicure, I do use a lot of Marquis for GI, and sometimes diet as far as ID or WD for the older cats or something, the fiber. Pain relief, again, I think that's something, these Panlu kitties seem to be painful. If you're sloughing your gut, a little buprenorphine might not be a bad idea, just a small amount anyway. So some diagnostics, it's not uncommon if we've got a clinical case to run a Parvo test or a Giardia test, and especially a fecal, not to forget the basics. Panleukopenia we also treat, and we're pretty good about not spreading it. So sometimes it seems kind of scary that how could you do that depending on, everybody has different setups in their place, but sometimes you don't know until you try. But and teaching your staff as far as whether it be, we use a lot of those butcher gloves, they're pretty cheap as far as per cage, especially with some of this infectious. We use trifectin a lot, sometimes dilute bleach, made up daily. Treat aggressively, treat early. Supportive care is critical, again, food, nutrition. Euthanasia, we don't, if I have a parvo-positive kitten, I don't put the whole litter down. I don't even put that kitten down necessarily unless it's not responding to treatment. So euthanasia is reserved to those that aren't responding. The older the patient, we find that the chances of recovery, that's not too surprising. But we have had cats that might be 10 months old that die of panleukopenia, but it's definitely more the exception. And know your ability to successfully treat and to save a patient based on age. So if I have a 1-pound kitten that's vomiting or has bloody stool, and especially if I have another sign with it, like doesn't look like it wants to eat when I open up a can of AD or something, then I might be more inclined that pet is suffering, and probably our chances of pulling that kitten through probably is not reasonable. So sometimes we will, if we think the prognosis is poor to grave, then we don't put them through that, and usually euthanasia. Adoption center, so our fifth component of the process. And healthy animals, hopefully to the adoption center, and you can see both of these pictures are taken at the adoption center that was built in '07. So the Purdue fellow, she's usually up there once a week, and she will assess the population if there's any pets there that they might have questions about. So especially your seniors, your kittens, puppies. And she's also looking at how they're doing in the setting. You might have some dogs that are 2 dogs in one room, and maybe one seems to be more stressed or maybe not showing well with that particular dog. Then she might make a comment as far as to reassess that. Animals that are ill come back to the Rescue and Recovery Center. So we try to keep it somewhat separate while being sensitive to what we're bringing back. There are a few cages there that they can treat medically, but we try to keep all the sickness at Rescue and Recovery and not at the adoption center. We can just watch them better and be more aggressive in how we treat. Educating, communicating with the animal caregiving team and the volunteers. So, as far as post-adoption, we have a really nice arrangement and relationship with VCA. And I used to work with VCA. Actually, that's how I got involved with PAWS. That's where we sent all our critical patients, and unfortunately, they just go back in isolation. But VCA has been extremely supportive of us. And when they're adopted, all medical files are reviewed with the adopter. So there's full disclosure as far as if a pet has seizures or a bite history or any other medical care. We're going to go over that with them. And 3 days after they adopt, VCA will do a complimentary exam. And usually it's up to $500 that they might do radiographs even. And so $500 in medical care that they'll do for the common shelter illnesses. And that's up for 2 weeks after they're adopted. And we're partnered with them, and they're very good about promoting shelter animals, which I think is extremely important. And there also is communication as far as if they have any concerns, that there's open lines of communication where we can talk about what they're seeing or things like that, and we may make changes as far as, so that's nice. As far as post-adoption support, adoption program, follow-up program. And this is very supported by volunteers. So they're checked on after they're adopted, a couple days after, a couple weeks after, 40 and 90 days. Foster to adopt. We have, I told you with a slow track that we do for the kittens and puppies, that they go out for adoption or maybe might be another adult dog, the cat, that goes out for a couple weeks. And sometimes those fosters will end up adopting them, so it's kind of a nice test drive. And a failed foster, we call it, and that's not a bad thing. So we serve as a resource for them throughout the life of their pet. Return at any time. There's a lifetime commitment. Once you're in the PAWS family, you're always welcome to come back. So we do get them back sometimes 6-8 years later or something. They might have diabetes, the people can't afford it, and so we are committed to them once they enter our facility. And volunteer-supported program, like I said. And this is Red, who was shot when there was a break-in and is now a paraplegic with a cart. PAWS is committed to making Chicago an adoption guarantee community. Like I said, we're on track for, in 3 years, we hope to, where they're not putting pets down due to space. And it's done one life at a time. And being innovative and a progressive shelter medicine program is vital to accomplishing this. So having goals and hopefully meeting them or finding out what it takes to meet those goals and just keep setting the bar higher and having really a can-do attitude as far as, none of this, we can't do it. I mean, I don't think I've ever heard that. And having a staff that is willing to think outside the box and keep trying and, everybody's input is critical. You can accomplish pretty great things. So that's all I have. So thank you.